relapsed and refractory AML can look different ways in the contemporary era compared to before. Before it was straightforward, we would see people who either responded or didn't respond to upfront treatment, and then we would see relapse down the road. Nowadays, we can see people who may have a morphologic remission from leukemia, but still have MRD using one of the molecular testing. And we know that this means that the relapse risk is higher. And so there are open questions about what to do. We also now are using less intense treatment that can prolong life, maintain good quality of life, but that may not lead to a complete remission. And so there are a lot of questions about how do we manage a situation where somebody is receiving an HMA and venetoclax, not achieving a remission, yet maybe otherwise responding. And then lastly, in patients who are treated with the less intense treatments, who aren't entering a remission, and eventually they progress. And in fact, patients who enter a remission progress if that's their only treatment. And in that setting, it looks differently often, and the options are different. And we're really unsure of what the next steps may be and how to address that group. So I think that's the first point. And then the second point is there are many new novel agents that are coming that have the promise of being able to treat acute leukemia, but in a way that may be better tolerated and almost may form a way of managing AML as if it's a chronic disease. So that's that's a very different paradigm than what we're used to. At the same time, we know that transplantation, which is a very aggressive option, the most aggressive option, is now more effective. It's less difficult and toxic. And we are able to treat patients who are up into their even late 70s. So how do we best manage these different options in this new era? It's a very open question.